Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer-reviewed and free.
Hi there, I'm Jo Chia, your host for this episode of the Australian Prescriber Podcast. Joining us today is Dr. Ganesh Pranavan, who is a staff specialist at the Department of Medical Oncology at Canberra Hospital. Dr. Pranavan and a team of authors have written the article Medical Management of Metastatic Prostate Cancer, which you can read in the October edition of the Australian Prescriber. GP, welcome and thanks for taking the time to speak with me today.
Thank you, Jo.
So GP, let's get started. Firstly, can you tell us a little bit about metastatic prostate cancer? Are there different types of prostate cancer?
The prostate cancer is divided into two main categories, early prostate cancer and advanced prostate cancer. The treatment for early prostate cancer is with a curative intent with radiotherapy and surgery, whereas the metastatic prostate cancer is a terminal disease but can be controlled for years these days. If the metastatic prostate cancer is again divided into two categories of hormone-sensitive disease and castration-resistant disease.
All right, so to follow on from that introduction, your article outlines a variety of treatments such as oral or intravenous medications, radiation and surgery. So you mentioned surgical and medical castration. Could you actually explain what these terms mean?
So the main treatment for prostate cancer is androgen deprivation therapy, or euphoria male menopause. In the past, people do have surgical castration or orchidectomies, where that's a way to achieve complete testosterone inhibition. These days, we use medical castration for many reasons. As surgery, it can cause a psychological impact. So currently, we don't do surgical orchidectomy. Most of the patients go on to medical castration with androgen deprivation therapy. The commonest implants are either GnRH analogs such as goserelin or leuprolin, commonly called Zoladex or Leucrin, or the newer antagonists such as Degarelix or Firmagon. These can be given, some of them can be given as a monthly injections through your GP, and some of them can be given as 3 monthly or even 4 monthly preparations.
So if a case is considered metastatic castration resistant, what are the current treatments available and the timing of when you would start them?
Sure. I would go through the treatment for both hormone-sensitive and hormone-resistant or castration-resistant cancer. The initial phase is when the prostate cancer responds to androgen deprivation therapy called metastatic hormone-sensitive prostate cancer. After a while, the cancer develops resistance to the androgen deprivation therapy and they start progressing on the androgen deprivation therapy. Then they are termed metastatic castration-resistant prostate cancer. In addition to the ongoing androgen therapy, the main drugs are docetaxel, cabazitaxel, abiraterone tablets, enzalutamide tablets, and the radium-223. And these drugs have shown to improve the survival significantly. The 4 drugs are available in Australia through PBS scheme. However, the radium-223 is not PBS reimbursed. There were some new studies done in the last 2-3 years looking at docetaxel chemotherapy being introduced at early stage in the hormone-sensitive phase. And there's significant benefit of survival, at least more than 14 months, but only in patients with high-volume disease.
So given that androgen deprivation therapy is the backbone of treatment, and you said that it's lifelong, is it something that needs to be given at a set frequency, or in your article you mentioned intermittent therapy?
So we look at intermittent androgen deprivation therapy in patients with non-metastatic disease with biochemical relapse, and that's shown to be non-inferior to the continuous dosing. In metastatic disease, we do not normally use intermittent androgen blockade. However, in a subpopulation of patients such as elderly patients or patients with comorbidities or people who have got low volume disease, there's definitely a role for intermittent androgen blockade therapy.
Okay, so according to your article, you've mentioned metastatic castrate-resistant prostate cancer is now considered a chronic illness. So how can GPs, specialists and pharmacists in the community work together to support the patients? And is there anything that we should be looking at, for example, serious drug reactions or symptoms of progression?
Prostate cancer has truly become a chronic disease now. For someone with a metastatic prostate cancer, the life expectancy would be more than 5 years. GPs do see these patients quite often from either symptoms related to the cancer progression or from the side effects. Supportive care can be again divided into two main areas. So one is looking at supportive care for cancer-related symptoms such as pain and fatigue. So patients with pain related to the bone metastasis, they need to have enough adequate painkillers. So there are many other symptoms could be from the cancer progression, such as decreased mobility or leg swelling. The other area would be supportive care for cancer treatment related symptoms. For example, the androgen depression therapy can cause worsening bone health, loss of libido, so it's very appropriate to counsel these patients at very early stage. If they got issues with bone health, we generally do a baseline bone density scan, and then we do bone density scan every year. There's also a role for bisphosphonates in patients with bone metastatic disease in castration-resistant disease. Biphosphonates and denosumab both have shown to decrease the risk of fractures and other skeletal-related events. It's very normal to see these patients with side effects related to these cytotoxic chemotherapies or these anti-androgens. For example, patients on abiraterone or enzalutamide have less side effects compared to docetaxel chemotherapy or other cytotoxic, and even they can have side effects such as tiredness, leg swelling. Abiraterone can cause issues like hypokalemia, low potassium. It's very important for the GPs to know the common side effects of these drugs. Chemotherapy, as we know, causes febrile neutropenia or increase the risk of infections in us.
Yeah, so it's really important for GPs and even community pharmacists who may be involved in dispensing the medications to be aware of some of those side effects that you mentioned. In our day unit at my workplace, the ward pharmacist also tries to get involved and ask the patient about their mouth health, and we're reviewing blood tests as well. So we do understand how important it is to be looking at those sorts of things. Yeah. So what sorts of drugs or regimens are you currently seeing in clinical trials, and are you anticipating any big changes to therapy in the next, say, 5 to 10 years?
The newer drugs like immune therapies and PARP inhibitors do have a role in prostate cancer. There are studies going in many of the states looking at a combination of immune therapy with Taxol-based chemotherapy or other cytotoxic drugs, or PARP inhibitor and chemotherapies, or immune therapy and new anti-androgens.
That's good. I'm excited to see what happens in the next 5 to 10 years in that space. So GP, that's all the time that we have for today. It's been a pleasure having you on the program.
Thanks, Jo. Nice talking to you.
The views of the hosts and the guests on the podcast are their own and may not represent Australian Prescriber or NPS Medicine Wise. I'm Jo Chia, and thanks for listening.